From the Heart.org Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Arthur L. Bloomfield Professor and Chair of Medicine at Stanford University.
Hi, this is Bob Harrington on the Heart.org and Medscape Cardiology. We're in the midst of a really unprecedented situation across the globe, here in the United States, here in Northern California, where I am now, with the COVID-19 pandemic. It's really brought out in many ways some of the best of society in terms of people joining together to work hard to figure out how best do we address this as a society. But it's also brought out some of the glaring inequities in our society around who gets sick, who gets health care, who gets good health care, who suffers the most. And so I thought it would be an opportunity to share with our Medscape Cardiology audience a discussion, one of the leaders in the cardiovascular community, on helping us research, think about, and then communicate these issues of health disparities, health inequities. And I feel really honored today to be joined by a good friend and colleague, Dr. Michelle Albert. Michelle is a professor of medicine and the associate dean of admissions at the University of California, San Francisco Medical School. She's also the director of the Center for the Study of Adversity in Cardiovascular Disease. And importantly, in terms of this conversation, is that she's the new leader, the new president of the Association of Black Cardiologists. So Michelle, thank you for joining me here today on Medscape Cardiology.
Hello, Dr. Harrington. Thank you so much for having me.
Well, Michelle, I have known you a long time, and I was delighted when you took the reins of the Association of Black Cardiologists. In my role as the president of the Heart Association, we share a close collaborative relationship with the ABC. Before doing this conversation, I visited the ABC webpage, and I saw your letter to your membership that was termed "What COVID-19 Means for Black Communities." So let's start the conversation there. Why did you, as the leader of the organization, decide that you wanted to put this out?
We were hearing reports that many in different Black communities across the country were not taking COVID-19 seriously enough. There were individuals who felt that COVID-19, quote unquote, did not affect Black people. And we became concerned upon hearing some of those anecdotal reports, because we know that there are stark health inequities in the United States, and with a viral infection, that the likelihood of amplifying the health inequities that we know exist by race, ethnicity, and socioeconomic status would be immense. Subsequently, we have all been privy to, in the media as well as in our own practices over the last week to 2 weeks, the startling death rates, especially of African Americans related to COVID-19 infection vis-a-vis their the population prevalence of African Americans. There's a discongruency within the various in New York, in places like Louisiana, in Chicago, in Detroit, wherein it is noted that there's a doubling of deaths from COVID-19 among individuals who are African American relative to their proportion in the population. As an organization that is exquisitely interested in the care in diverse communities, especially among Blacks, we felt that it was really important to put out a call to action related to increasing awareness, both at the community level as well as at the levels of healthcare, about the potential impact of COVID-19 in Black populations.
Michelle, early on in reports coming out of China and then subsequently places like South Korea, it was noted that people who fared the worst with COVID-19 included those with cardiovascular comorbidities that included hypertension and heart failure. It also included people with advanced lung disease. Are the inequities in terms of outcome, or the disparities in terms of outcome, is it all explained by the confounding comorbidities, or is something else here that we need to pay attention to?
I think that there are multiple factors that contribute to these inequities. As you've already alluded to, COVID-19 complications and death rates are tied intimately to having underlying chronic medical conditions such as cardiovascular disease, asthma, COPD, all of which are more prevalent in the African American community. However, I think additionally, there are a number of social factors that are at play here. One relates to segregation and discrimination, wherein African Americans and other racial and ethnic minorities, such as the Latinx community, live in environments wherein there's overcrowding, live in multi-generational households where it is difficult to socially distance. They also work in jobs that are disproportionately service-oriented jobs that cannot be done via teleworking, and hence have to go out to work, take public transportation, with all factors which increase risk of exposure to COVID-19.
Yeah, it's been really striking. There's been stories of bus drivers in Detroit almost valiantly coming to work every day with the notion that they're in a packed environment, but yet they feel an obligation to do their job. And
Absolutely.
They're disproportionately Black, as you've said.
Right, absolutely.
Your own chair of medicine, Bob Wachter, who I've been talking with throughout this and who has been chronicling what goes on at UCSF every day during this time, wrote, I thought, very poignantly last night is, hey, I have an internet connection, I have Zoom, I can do my job from home, I'm living here with just my wife and my dog, I've got room to distance. Let's be honest, it's not everybody who shares that. And he really used his own personal example to call attention for the rest of us to say, hey, wait, pause. It might be uncomfortable, if you will, to social distance. But for some people, just to get through their daily life, they can't socially distant.
Correct. And I think that the other issue beyond social distancing relates to access to care. The flagrant issues that affect access to care for minority communities, particularly Black and Latinx communities, is also at play here. Folks are staying at home, as you know, and not going into clinics or hospitals when they become symptomatic, even with their cardiac conditions. And the same is true related to this COVID-19 pandemic, wherein folks are afraid actually to go into the hospital if they have a cough or have a fever. And this is true in the African American community as well, wherein there's also a level of distrust of the medical system, coupled with the fear of, sort of going into a hospital at this point in time. So I think in addition to some of the other social factors that we've already been discussing, as well as underlying chronic health conditions, there's also the issue of presenting for care and perhaps possibly even presenting to care later than they should present to care in the current context. The other thing I wanted to talk about, Bob, is the issue of testing and accessibility. My entire family is in New York City. And, if one is symptomatic, that is, if one has a fever and a cough, and one calls one's, sort of healthcare provider, chances are one will be told to actually stay at home because the system is so overwhelmed, unless one has shortness of breath or other really concerning symptoms. These are issues because in multi-generational households and also in overcrowded communities, wherein one may actually have COVID but hasn't actually been tested for COVID, the infectivity rates are going to be pretty high, and folks aren't going to know, whether to quarantine or not. And I think this is a particular issue in minority communities and African American communities that are not going to necessarily be close to academic medical centers and testing facilities. So one great need in the context of this pandemic is actually to not only ramp up testing, but also making testing easily available in communities of color.
That's a really important point. As we move beyond just using the PCR tests, for example, to look for the presence of the virus, we're going to move into an era where we also want to test serology. We don't have a definitive sense yet of what does that mean in terms of conferring a level of immunity and resistance to future infection. But we're learning constantly. And I think you're absolutely right that you and I both live and work in an academic medical center where those facilities will be available. We need to really, as a society, set up testing venues that allow broader access, don't we?
We do, and getting to the sort of the biology of this and immunology of this, there are two phases of testing, right? There's testing for the virus, which would be in an early stage infection, when the infectivity rates might be pretty high. But as you mentioned, in terms of antibody testing, that's really testing for exposure to the virus. And certainly, as the antibody tests come on board, the utility of antibody testing may be, at least initially, most useful for healthcare workers in particular, to know who has been exposed and who hasn't been exposed, to help protect patients and other folks they may come in contact with. But you're right, as the tests become more specific and sensitive, and as these things get developed, antibody testing will be important to understand the population immunity levels.
Yeah, and it's going to be important not just for the jobs that you and I do, which is work in a healthcare facility, but it's going to be really important in terms of opening up broader society. When can companies reopen? When can stores reopen? When can people begin to get back to some sense of normal? It's going to be a while before we understand all of these issues, which I'm seeing from your comments further will have an effect on health inequities as we continue to have a slow ramp up of our economy and getting back to normal.
You mentioned the economy. One of the biggest concerns I have related to this pandemic is the unemployment rates are skyrocketing in the country. Traditionally speaking, the unemployment rates in the United States for African Americans are usually twice that. That's the only reported unemployment rates, because as you know, after a while, folks will stop documenting that they're unemployed. So in general, we know that the rates are twofold higher, at least the documented rates, which means that they're probably threefold higher than the unemployment rates of whites. And given the scope of this pandemic, massive concerns about the unemployment rate among African Americans being upwards of 25 to 30% in this country, which is terrible. We already know that African Americans are paid much lower than whites in this country. We know that access to jobs dictates access to education, dictates access to home ownership. We know in the United States, African Americans have a home ownership rate of, about 45% compared to 77% of whites. So these things really hit the bottom line of what helps to dictate advantage health. Advantage health is not only dictated by biology, but it's dictated by sociology and the social determinants of health. And mostly, and as you know, Bob, as a cardiologist, we know that 80% of cardiovascular conditions dictated by social factors. So I'm very concerned about the economics of this and its impact on the health of not only adults who are unemployed, but also their children, who then also suffer, whether or not children are being affected by this pandemic in a similar way to adults, at least at a biological level, is still up for the debate. But I think at the end of this, certainly for Blacks in this country, that the effects on children and adults are going to be enormous.
The profound nature of it really came home for me several weeks ago when New York City was publicly having the debate about closing their public school system. And the mayor said on more than one occasion, I'm reluctant to shut down the school system because a sizable portion of our school population gets their only meals of the day from the school. And it gets at what you're saying, Michelle. It's not just biology. There does seem to be something unusual about the virus in the terms of how it does not seem to at least in the most severe forms, affect children in a broad way. But there's going to be side consequences here that include malnutrition and food insecurity and a variety of other things that the pandemic is going to leave us with.
Right. Food insecurity, housing insecurity. And then there's also the issue of educational disparities. We know that there are educational disparities by race, ethnicity, and by socioeconomic status. We've moved to virtual classes at this point, and Black and Brown communities are struggling to bring computers into the homes. Many minority communities, especially African American, receive their internet via their phone and not necessarily by a desktop computer or a laptop computer. So one of the things that local governments and states will need to focus on as it relates to education, especially if this pandemic is protracted, is how do we bring technology into the homes of folks who tend not to have access to the types of technology that are needed for this ongoing pandemic.
A couple of hours ago, I was involved in a conversation with the Heart Association about telehealth. And while we've seen this acceleration of the use of telehealth throughout our systems, it's really taken off here at Stanford. Something that during this call that was brought to everyone's attention that we have to be on guard for, it can also accentuate health inequities for the reasons that you've already mentioned. Is that if you don't have the ability to have that video connection with your health provider, either on their end or your end, it leaves you, again, perhaps unintentionally, but realistically getting less access to care than you warrant.
Absolutely. And something that Bob that always has, sort of bothered me about telehealth is my patients who are African American have tended not to want to do telehealth because sometimes as we do telehealth and we do video, you have a scan of the back of your background. And a lot of times people don't necessarily want, folks to see where they live. I know we can do virtual backgrounds with Zoom, but we make large assumptions that everybody wants folks to, sort of see where they live or have a snapshot of a bookcase in the background, et cetera. And folks can have feelings about that, which others might take for granted. Also, with the distrust of the medical system, the historical distrust of the medical system that African Americans have, I do have concerns about how that distrust interfaces with telehealth.
Yeah, I completely agree with that sentiment. I've been doing my own cardiology practice visits using both phone and video, and I definitely have patients who have said to me, I'd prefer that you call me as opposed to being on video. And I suspect that there are issues of what people feel comfortable with, et cetera. And I do think that we as a community need to think about that and need to be both sensitive towards it, but also think about other ways that we can provide access and reliable, good, high quality care. I want to get us ending on a couple of thoughts, Michelle. One of which is we talked offline about a piece by our mutual friend and colleague, Clyde Yancey, out of Northwestern that was in JAMA today, where he covers a lot of the things you and I talked about. And then he asked the question, is this the moral moment for us as a society when we finally will do something about what we've known for a long time, that health inequities exist and that the social determinants of health contribute adversely much of what we know about the common chronic diseases like cardiovascular disease? What are the opportunities for us, Michelle, or to use this to do some good?
As you know, Bob, last week we had a webinar called At the Heart of the Matter, Unmasking the Invisibility of COVID-19 in Diverse Populations, put forward by the Association of Black Cardiologists. And in the last part of that webinar, we outlined potential opportunities. These include increasing testing and accessibility in all communities, particularly in disadvantaged communities, decreasing the impacts of segregation at the local level as well as the national level, ensuring that there's adequate employment opportunities available as we move through or come out of this pandemic, ensuring that educational opportunities that are lacking, particularly in Black or Brown communities, get focused on at both local as well as federal levels. I mean, we've had a lot of moral moments in throughout the history of the United States that we have never been able to get to the point where we pony up to dealing with these issues related to employment, related to jobs, related to where people live, how people live. And this pandemic, again, puts another earthquake into issues that we know are longstanding. There's no magic bullet, but certainly we need to double down on our efforts to focus on, I think, especially education, jobs, and providing equitable access to healthcare for all communities.
Our friend, who you know well as well, Eduardo Sanchez, who's the Chief Medical Officer for Prevention for the Heart Association, has reminded me that it's not just social determinants of health. These are structural determinants of health, and you've laid them out really well and really called upon us to act together to do something that many of us have been chipping away at for many years. But I do agree with you. Now's the time that a pandemic has uncovered the real failings of our system, and we have to do better. Certainly from a Heart Association perspective, we're really privileged to collaborate with your group at the Association of Black Cardiologists to see if we can make a difference.
I just wanted to add that one of the things that I think the American Heart Association does well and is doing in this crisis is making grant funding available to examine these issues so that we can have targeted responses to the effects of the pandemic, not only related to health, but also related to those structural determinants of health.
Thank you for bringing that up. Yes, we hope to be announcing those grants very soon. Michelle, thank you for joining me here today on the Heart.org Medscape Cardiology. And I want to thank our listeners for staying with us in this interview. It's been a privilege to have Dr. Michelle Albert, Professor of Medicine, Associate Dean of Admissions at the UCSF Medical School, and the Director for the Center of Adversity and Cardiovascular Disease. Michelle is also serving this year as the President of the Association of Black Cardiologists. Dr. Albert, thanks for joining us.
Thank you for having me.